So I would like to request your cooperation, sir. For our quality assurance process, it is imperative that the framing of doctors' videos meets our quality standards. Therefore, I kindly request you to maintain a stable position and ensure proper camera framing throughout the entire session. Additionally, please refrain from engaging in any other activities while the recording is live. Furthermore, in the event of low network bandwidth, I recommend sharing your presentation from your laptop, and for verbal communication, kindly join the session using your mobile phone. Your adherence to these guidelines will greatly contribute to the overall quality and effectiveness of the recording. Thank you for your understanding and cooperation, sir. We'll be going live in a minute.
Okay.
So please, 1 minute, like it's 6:30, so we'll start right now. So
Oh,
after the introduction, then you can begin with the PPT. Okay?
okay.
Yeah.
Still I wait. Still I wait. Okay.
Yeah. Yes, sir.
Okay.
Greetings and a warm welcome, everyone. I am Asya, the assigned moderator from Clarinet. It is my pleasure to extend a heartfelt welcome to all the delegates joining us from across the country. We are indeed fortunate to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us today. Allow me a moment to introduce our platform Clarinet to you all. It proudly stands as one of the largest live digital continuing medical education platforms in India, providing a space for doctors to create and share medical content. Now, I would like to extend a special welcome to today's distinguished speaker, Dr. Raj Soni, sir, holding the degrees of MBBS, MD, Radio Diagnosis, DM, Interventional Radiology, Clinical Fellowship, Neurointervention. He is currently practicing clinical fellowship in neurointervention at CHU de Montpellier. The topic of today's session is interventional radiology pinhole surgery. I would like to give you an overview of today's topic before we start the session. Interventional radiology, offering minimally invasive pinhole procedures with short recovery times, is becoming increasingly popular. Pinhole surgery is performed using image guidance such as ultrasound, CT, or fluoroscopy. Through small incisions, radiologists insert catheters, needles, or other instruments to treat various conditions. Any organ can be accessed through this technique, allowing a range of procedures to be performed on different organs. Common applications include angioplasty, stent placement, tumor ablation, and embolization. This technique reduces patient trauma, lowers infection risk, and shortens recovery time compared to traditional surgery. So, without any further delay, I would like to hand over this session to Dr. Raj Soni, sir. Kindly proceed with your talk, sir. Over to you.
Thank you for a kind introduction. Thank you for a kind introduction.
Thank you, sir. Sir, can you please minimize that box because it is coming in between the PPT? You can minimize it, sir.
Okay.
Yeah. Yeah, sir. That's fine. Thank you so much.
Okay. So I'm Dr. Raj Soni, interventional radiologist, and I will take in the next 30 minutes. I will take you to the interventional radiology, like the topics from head to toe we perform in the interventional radiology, and I will give you a basic background of it.
I'm so
So
sorry to interrupt you again, sir. Can you please turn on your video, please? It's not visible. Yeah, now it's fine, sir.
it's good.
Yeah, better, sir.
Okay. As we all know, the Salinger was the first person who was a radiologist and he was the first and the pioneer for interventional radiology. So he had his technique for localization of tumor, which was done by radiography. He did renal angiography and cholangiography. And as we all know, the puncture which we do in the interventional radiology was pioneered by Seldinger. But it was Charles' daughter who just began the technique for the angioplasty. And he laid a foundation for the interventional radiology and the angiographic catheter. And he told that angiographic catheter can be more than a tool for a passive means for diagnostic observation. And its use with imagination, it can become an important surgical instrument. So it was the beginning for the interventional radiology in 1964. So generally, we are like a medical plumber. Our goal is to just blocking the leaks and opening the blocks. So I'll just show you the basic diagram, how we perform the angiography. We just do a puncture, and through the guide wire and catheter, we'll use to cannulate the singular vessel. Here we cannulated the brachiocephalic trunk and enter into the carotid artery. So there are the venous, we go through the venous route and the arterial routes, and there are for different, I will take you all the intervention from basic cases from head to toe interventions. So let's begin with arterial occlusive disease. So for arterial disease, it's the same, like we do a balloon angioplasty, subintimal angioplasty, we use stenting, cover stent, a cryoplasty, and a thrombectomy device, which do recently for the cathetic lesion. So this is a schematic diagram. As we all see, there is a plug and there is a luminal narrowing. So we'll expand the balloon and it will help to resolve the symptoms, and we can see the results. So, and sometime if there is not a proper opening of the vessel, even through a balloon, we need to put a stent, and stent is made up of meshwork, and we can see it as shown in the diagram. Also, we use stent in case of unstable plaque fracture, as shown in the diagram. So also when you balloon angioplasty, there may be an elastic recoil of the vessel. So even after the balloon plasty, the vessel wouldn't expand. So we need to use a stent for it. So for angioplasty and stenting, as we see in this figure, there is a ostium lesion of the right iliac artery. So in order to open this, we will puncture from the groin region, cross the lesion with the small wires, and after crossing, we'll do angioplasty and stenting of the lesion. Here we have a bilateral iliac stent introduced. And we can see the new vessel. So now let's move to the stroke. So basically, the brain receives blood supply from the two sets of blood vessels, the carotid and the vertebral arteries. And if any of the vessel is stenosed or there is a clot migrated from the heart, the patient may experience transient ischemic attack. If in transient ischemic attack, one may experience the transient loss of consciousness, weakness, or blurring of the vision. So we perform a CT angiography and Doppler and MR angiography to diagnose lesion. This is one of the cases. There was a stenotic lesion in the basilar artery, and we performed a balloon expandable stent after angioplasty, and we can see the patient recovered from his symptoms. Another lesion is of a carotid artery. There was a significant 80 to 90% stenosis of the carotid artery, and we performed a stent, and we can see the artery is open. So in case of carotid artery stenting, we distally place a filter before putting a stent in order to prevent the clot to migrate into the brain. Here is another case. You can see there is a stenosis at the subclavian artery, and we put a stent into the ostium of the subclavian artery. Now let's move to another region of the abdomen. As seen here, there was a ostial stenosis of the celiac artery, and we performed a pigtail angiogram, and then we put a stent, and the patient had relief in the symptoms. This was another case. There was a stenotic lesion in the renal artery, and we performed renal artery angioplasty and stenting. There was a patient came into the OPD with a bilateral claudication, pain, and impotence, and there was a stenotic lesion at the aortic ostium. We put a self-expanding stent, and we can see the vessel getting open. There's another case. There is a stenotic lesion. The ostium is not seen of the right iliac artery, and we open the vessel with the help of stenting. The next case, there was a superficial femoral artery. There was complete occlusion before the procedure, and we can see the stenosis. And post-procedure, we can see how the vessel is opened due to stenting. So these are the stent we use for the superficial femoral artery. This is another case of pop lesion. The patient came with a limb claudication, and we can see the extensive collateralization of the vessel, and we can see the image on the right. We can see a new artery getting reconstructed, and it was possible just by stenting. This was a case of the below knee angioplasty. The patient came with a ulcer in the first toe, and there was a claudication pain, and there was multiple collateral. We crossed the lesion, did a balloon plasty, and opened the vessel. This is another case of the posterior tibial vessel. You can see the narrowing of the posterior tibial artery, and after angioplasty, the vessel opens. So, and sometimes the patient with peripheral vascular disease may have renal disease, or if they have a poor cardiac function, or they have allergy to contrast. We can also do a CO2 angiography in order to protect their kidney and the renal function of them. So these are the patients we have done with CO2 angiography of the lower limb. Also, in case of renal artery, we are done with a CO2 angiography. You can see the stenosis, and we did a balloon angioplasty and stent. So next topic is the cover stent, and cover stent are basically used to protect the endo leak, or in case of there is a rupture or there is a long segmental occlusion. So this is the basic phenomena of the if there is a dilatation of the vessel, there will be a thrombus, or there will be aneurysms, or there will be the endo leak. So in order to protect this, the cover stent will do the job. This is the case. We can see there is a endo leak, extravaginal contrast from the common cavity artery, and we put a cover stent, and the patient was symptomatically good. And in the case of the subclavian artery, we can see a huge pseudoaneurysm, and we put a cover stent, and the patient was really, really good. And another case, there was a long segmental aneurysm in the popliteal artery, and we put a stent graft, which is a cover stent in the popliteal artery, and you can see the patency of the vessel. Also in the aortic aneurysms, we also use a technique called EVAR, endovascular aneurysm repair, in which we use stent graft as we use for the endo leak. So we can see this. This is the body of the stent graft. So in this technique, there is a infrarenal aortic aneurysm. So we just do a puncture at the groin region. We'll do a pigtail angiography to see the extent of the lesion, and just we'll put the stent from the one side, and the contralateral limb will be put in from the opposite side in order to prevent the endo leak. This is an example of abdominal aortic aneurysm repair. This is a pigtail shoot, and for the embolization, we have like different materials available in the market, and they are like particles, like liquid embolic agent, coils, detachable balloon, glue, alcohol, gel form, which are the temporary embolizing agent. So the particles, So this is the basic goal of the particles we use as embolizing agents. We use to create for the bleeder. If there is a bleeder, we can use particles smaller, and the smaller the particle size, the better the devascularization. Smaller the particle, but increase the risk of the ischemic necrosis of the normal tissues. This is an example of coiling done, and there was a aneurysm in the gastro using the artery, and we did a sandwich technique, one coil distally and one coil proximally in order to prevent the collateral supply, and we can see the aneurysm is excluded. And there was a detachable balloon we basically used for carotid cavernous fistula, and the code detachable balloon was used. Glue as a liquid embolic agent we can also use for this. We can see there was in this patient, it's an illustrative example. There was a leakage from the internal iliac artery, and we did the coiling to prevent the leak, as same as the sandwich technique. Okay, now move to the next topic of head and neck. This is a case in which we can see there is a case of 32-year male which was stabbed on the left side of the neck and was rushed into the local nursing room to control active bleeding, and bleeding vessel could not be exchanged. So we take a left vertebral shoot and we can find there is an endoleak. And we do occlusion of the left vertebral artery, and we can see the other vertebral artery is patent, and we stop the endoleak. These are the post-coiling. This is another case of constructive worker, and the patient came with hypotension and tachycardia, and CT revealed the hepatic and the mesenteric active bleed. You can see the active bleed, the contrast, and we directly took into the cath lab, and we did the embolization of the selective branch of the hepatic artery, and the patient was good. We can see there is active leak in the iliac branch of the supramesenteric artery, and we did a coil embolization. And post-procedure, there is a cessation of extravasation. Another case of pseudoaneurysm, there was a leakage from the splenic artery, and we just occluded the parent artery. Another case of renal trauma with active early bleeding, and we again did a coiling of this. This is a case which is a non-traumatic. There was a pseudoaneurysm in the gastroduodenal artery, and we just gelled with coils. The same is the case with pancreatitis or upper GI. Also, the case we can see there is extravasation of contrast on one of the branch from the jejunal artery, and we did the coiling, and the extravasation was stopped. Also, we have role in hemoptysis. We do a bronchial artery embolization. In case of significant hemoptysis, so you can see there is a right intercostal artery which is tortuous. There are few pseudoaneurysm. There is increased hypervascularity, and we give PVA particles of 300 in size, and we can see the disappearance of the hypervascularity and the tortuosity of the vessel. There was a bleeder which was coming from the inferior phrenic artery, and with the post-embolization, it was good. This is a case of there was a bleeding in the patient and the pain in the flank pain due to the rupture of the angiomyolipoma. With the help of onyx, we just excluded the bleeding. This is a case of a post biopsy. There was an AV fistula with early draining vein, and we had a liquid embolic agent. We can in the coils, and we can see the result. Also, we use for the postpartum hemorrhage. We do uterine artery embolization with help of PVA particles more than 500 ml. Also, our role is in tumor embolization in case of hepatocellular carcinoma also. So yeah, this is a schematic diagram of the uterine artery embolization. We take a catheter, we can relate the interiliac artery, we can relate the selective uterine artery, and then we introduce the PVA particles. And we do on the same thing on the opposite side. We can see there is the images in which there is a tortuosity of the uterine vessel, and there is no ovarian connection. So we'll go distally in the uterine artery and give the PVA particles of 500 mm. You can see the post-op result. And we do a MRI for the baseline and the follow-up, 3 months and 1 year. There is a significant reduction in the size of the fibroid. Same we use for the hepatocellular carcinoma, which is supplied from the hepatic artery. We do a selective angiogram, see the tumoral supply, do a cone beam CT, and then embolize the tumor and see a follow. Also, there's role of in case of pre-op tumor embolization. In highly vascular tumor, we introduce a gel form particles, and we can see the contrast bullous in the first image, and it was supplied from the ascending pharyngeal artery, and we see the post-op image. There is no contrast blush, and patient can be sent for surgery. Also, we use for different vascular malformation, we use a percutaneous sclerotherapy with the help of sodium tetrahydrosyl sulfate. We mix with the three-way syringe, and with the help of butterfly needle, we use for slow flow vascular malformations. Also, the use for the intracranial malformation in case of AVMs, we introduce a glue or a Minox or Onyx for. Also, in case of orbital AVM, we can see the tumoral blush, we can see the multiple feeders, and we did introduce a glue in this patient. Also, there is a role in keratoconus fistula. There was a patient with keratoconus fistula, and we did the stent graft. Also, we used to treat the pulmonary AV fistula. You can see there is a pulmonary AV fistula. We go through the femoral vein, cannulate the pulmonary artery with the help of guiding sheath, and introduce the coil or the plug we can use. So for the intracranial aneurysms, the ACOM is the most common, which is 30 to 35% chance of aneurysms. And the size of the neck will determine we can do the coiling, simple coiling, or we can use a balloon, or we can use a stent. If the neck is small, we can do an unassisted coiling. If the neck diameter is large, we used to use a something protection device. In case of narrow neck, we do simple coiling. In case of wide neck, we need to either do a balloon assisted or stent assisted coiling. You can see this is a posterior circulation, side wall stent assisted coiling. Also, there is a role of interventional radiology in case of venous intervention. In case of venous intervention, if there is a stenosis, we do a pressure gradient measurement. And if there is a significant pressure gradient, we measure it and we do a balloon angioplasty. And you can see the IVC obstruction, we just open with the help of balloon angioplasty, and then we put a stent. We perform a TIPS in case of liver cirrhotic disease. We calculate the MELD score. We will do entry from the interventricular vein, do the selective hepatic vein, then enter into the portal vein and create a tract, and then put a stent in order to prevent the portal hypertension. Also, we have interventional radiology role in case in deep vein thrombosis. The goal is basically to recanalize the thrombosed vessel, prevent the progression, and prevent the pulmonary embolization. And also, we can treat the symptoms of the post-thrombotic syndrome, such as edema, pain, varicosities, hyperpigmentation, subcutaneous fibrosis, and ulcer. So, this is the basic things we want to prevent. And therefore, we need to treat the acute deep vein thrombosis in order to prevent the symptoms of post-thrombotic syndrome, which is really significant to the patient. So this is the patient, and this is the catheter-directed thrombolysis for the patient. This is a normal venogram. We can see that there is a thrombus in the long segment, and this is after post-thrombectomy urokinase. We can see the vein is reconstructed. So for deep vein thrombosis, we put the IVC filter so that the clot doesn't migrate into the lungs. So this is the filter we put, which will help to prevent the clot to migrate to the lungs. In the USG, you can see there is a iliofemoral DVT. We put an IVC filter, and then we did our promenade. Thank you. Hello.
Thank you so much, sir, for your wonderful deliberation and insightful content. And sir, we have received a few questions from our participating doctors. So may I have your permission to present them, sir?
Yes,
Sir.
sure.
Okay, thank you so much, sir. Please give me a moment to share my screen. Sir, is my screen visible to you?
Yes.
Okay, sir. So I'm putting forward the questions. Please kindly answer them.
So post effect, it's a simple thing. Like post effectiveness, definitely. If consider the example of yourself, if you have something in the brain, you will prefer opening the skull or directly go with a pinhole. So now the patients doesn't want to go for high risk procedure like open surgery or something. So the pinhole surgery is a game changer, and we just go to the brain with the help of one needle and a single pinhole from the groin region or from the hand, from the radial region. So I think the patient, if the person is skilled for a pinhole surgery and both things are available in the department, the patient will demand for the pinhole surgery, and it is replacing traditional surgery currently, like in many procedures. So the recovery process for the pinhole surgery is very easier as compared to the traditional surgery, and is like a daycare surgery. Sometimes patient can discharge in the next day, but in case of traditional surgery, you need to stay for the 1 month, and it is definitely much more costlier, and there are more risk of the infections for the patient from the hospital acquired infection, pneumonias. So there are no specific rehabilitation protocols in case of pinhole surgery. It's much safer than traditional. Already many things are AI driven into the pinhole. You see, in case of stroke, we have a rapid program, which is an AI driven program. When the patient comes, we do a rapid program. We do where there is a stroke, and we can see the mismatch. And definitely, AI driven has definitely changed the field.
Thank you so much, sir, for answering all the inquiries of the participating doctors so well. We are glad that we conduct a session with you on our platform. And, sir, thank you so much for giving your valuable time and for sharing such valuable insights with us. So, sir,
Thank
with your permission, can we conclude the session here, sir?
Sure.
Thank you so much to all the participating doctors for your consistent engagement on the platform. And lastly, before ending the live, I would request you all to follow us on our Facebook, Twitter, LinkedIn, and Instagram pages to stay updated for the latest medical information. So, with everyone's approval, we are bringing this session to a conclusion. Thank you so much, sir. Have a great day ahead.
Thank you.
Thank you, sir.